I know we left off in the last teaching time with talking about EKGs, but I want to pretty much devote this teaching time just to cardiophysiology, so how the heart works. And I think we need to refresh your memory with regard to how we know how the heart works, and that's the EKG. But just kind of refresh your memory that there are two types of cardiac muscles. There are the conducting system muscles and the contractile muscles. About 90% of the cells that are made up of the heart are contractile cells. These conducting system cells are the cells. You actually have a nice image in your book, but this one didn't come from your book, but I do like this one. Where it shows the junctions between the cells actually have gaps in them. You have these gap junctions. These gap junctions allow for the electrical impulse to be passed through all the contractile cells in a very, very rhythmic way. So the conducting system, the muscle cells of the conducting system, their job is to control and coordinate the heartbeat. They do this because of their design. They do this because the electrical impulse and also the ions are able to pass through in a very, very methodical way. The contractile cells produce the contractions. And other cells that you have, about 1% are autorhythmic. And they work, about 1% of the cells are autorhythmic. They work without any kind of neural or endocrine stimulation. And these are the cells that one hears when one hears their, the beginning of the fetal heartbeat. These are the cells that you hear then. The heartbeat begins at the SA node, so the action potential. And just to refresh your memory about an action potential is you always have a transmembrane potential between outside the cell and inside the cell. And when that transmembrane potential gets to the point where there actually is a discrepancy between outside and inside, we consider that the action potential. So the action potential is lowest for the SA node, for the pacemaker node. And so that when the entire electrical system becomes depolarized, then the whole impulse is sent throughout all of the cells all the cells of the heart. In terms of so we have a complete cardiac contraction. The overview of physiology. This cardiac cycle, this is one complete heartbeat where you have relaxation followed by contraction. The stimulus happens in the SA node, then passing it via this conducting system through all parts of the heart. The cardiac cycle maintains blood pressure, generates an EKG, and creates the heart sounds. The conducting system of the heart, just to refresh your memory, includes the SA node. The SA node is located in the wall of the right atrium, near the superior vena cava. Also the AV node, the atrioventricular node, and this one is located at the junctions between the atria and ventricles. And then the conducting cells, those are two nodal ways that impulses are distributed throughout the myocardium, and that includes the AV bundle, the bundle branches, and the Purkinje fibers. The SA node action potential is about 80 to 100 times per minute, whereas the AV node action potential about 40 to 60 times per minute. The AV node begins the action potential, spreads it via the AV node. So the SA node, I think I said that wrong. The SA node begins the potential, spreads it to the AV node. The impulse is delayed at the AV node, and then it travels down the bundle branches to the Purkinje fibers. The idea behind the heart, the impulse conducting through the heart, this one, what this one is doing, it basically is saying the same thing 3 times over, but that's fine. It's good to hear it again. You see the at the top left, step 1, SA node and the time, and then it's distributing it to both atria in step 2, and just a fraction of a second has taken place. Then all the atria become polarized, or become give the potential to contract, and then down the bundle branches. When it goes down the bundle branches and up the Purkinje fibers, then you have all of the ventricles ready to contract. And what I mean by all of them, all the contractile cells. Here's an image of a young man. Yes, he's a young man with an EKG. This is a pretty old school EKG right here, because they're much smaller now and not quite as scary maybe. And the thing about the EKG is this is our imaging of how the heart is working. The parts of the EKG, just to refresh your memory, you have the P wave, which is atrial depolarization. Depolarization is the same as contraction. So the P wave is atrial depolarization, in parentheses, contraction. We look at not only the strength of that contraction, so how far the wave deflects off the baseline, but also how long that contraction takes place, so the interval. The QRS complex is when the ventricles depolarize. Depolarization, again, is the contraction of those ventricles. We are looking at how strong that contraction is and how long it takes for that contraction to take place. And then the repolarization of the ventricles is basically the amount of relaxing time, and when we say relaxing time, the amount of time those ventricles are given to actually fill. So when we think of relax, we think of maybe the muscles relaxing, but also gives the heart time to fill. If these contractions happen too fast, it's wonderful. The heart is contracting, but it's not being allowed to fill with blood. And remember, the whole goal of the heart is to contract and move blood through your systemic circulation. And then the U wave is it's the blood pushing against the atrium. I'm going with that. I'm not perfectly sure about that, but I'm going with that one. The idea about those contractile cells and certain information that you want to know about that is what happens is you have your membrane potential. Your membrane potential is about negative 90 degrees is your membrane potential. And I don't actually have it on here, but it's a negative 90 degrees, negative 90 millivolts. We record this in millivolts. Oh, I do have it on here. Resting potential, approximately negative 90 millivolts. What happens is the sodium channels open up, and that allows sodium to run out, and that then changes the polarity between outside of the cell membrane and inside the cell membrane. That's what we call this rapid depolarization. So you have this rapid increase from a negative 90 up to basically a positive 30 almost. And then what happens is it gets to the point where the sodium channels are no longer able to put out more sodium, and they also tend to close up. But what happens then is calcium is released. But calcium channels work much differently than sodium channels. And so the sodium channels, they are gated, voltage gated. Sodium is voltage gated. And so, of course, when the voltage changes, those gates are going to close. The calcium channels are slow, and so it releases the calcium in a very, very slow way. And then what happens on top of that slow release of calcium, you have calcium in the outside the cytoplasm in the interstitial space, but you also have calcium, if you remember from 141, stored in the sarcoplasmic reticulum. And that calcium from the sarcoplasmic reticulum is also released. So that creates this plateau phase. And the plateau phase is basically kind of a few seconds where there is no chance for another action potential to take place. This absolute refractory period. There isn't a chance for another action potential, so another heartbeat can't happen. However, there is a small period after the absolute refractory called the relative refractory period. So the absolute refractory and relative refractory period. The relative refractory period, if the next action potential is strong enough, it can trigger another contraction. And that's where we get this AFib, where we have contractions that are a little too fast, not allowing this phase to go on. And then after the plateau, what happens is the calcium channels close, and then potassium starts rushing in. So then you have this rapid repolarization. So you have a rapid decline back to a negative 90 millivolts, otherwise known as resting potential. Just another little bit of review of the calcium. Calcium is around the myofibrils. Those are the contractile units of the muscle. The calcium enters the cell membranes during plateau, and then there's an additional release from that sarcoplasmic reticulum. Remember, that's around you have that around your skeletal muscles too, but these are cardiac muscles are involuntary, but they are striated. So their design is very similar to what you learned with regard to skeletal muscles, but they are involuntary. And then the comparing a cardiac action potential to a skeletal one. The cardiac action potential is much faster. So you have you're comparing the top two to the bottom two, and we're looking at the far right. The skeletal muscle action potential, you have basically the same design, although skeletal muscle is a negative 85, whereas remember the action potential begins in cardiac muscle negative 90, all the way up to about 30, so positive 30, but the skeletal muscle does not have that plateau, and actually the cardiac muscle, the contraction lasts longer. And the other thing about the cardiac muscle is there isn't a chance of tetany, not in the normal functioning of the cardiac muscle. There's not a chance of tetany because of that absolute refractory period. But the skeletal muscle is fast and tends to be able to follow up with another one very quickly in terms of an action potential. The other big difference is that the heart has a greater need actually for energy, and so you have energy produced by fats and also glucose that's stored not only near the heart, but also you have special myoglobin that can carry oxygen, because the heart needs a tremendous amount of oxygen to be able to contract all the time. We will pick this up on the next one.